Moroccan civilization, as we already said with Professor Tleveler just a few minutes ago. And he was elected head of the Department of Surgery since 2017. And he got his PhD in neurosciences in 2018 and in the Faculty of Sciences of the University of Fez. And obviously he participates actively as educator in the team of WFNS Rabat Reference Center for training young neurosurgeon, African young neurosurgeon. He's editorial from board of Journal of Neurosurgical Neurology International and published more than 70 papers. May I ask you, as Vice President of Moroccan Society of Neurosurgery, to introduce our first eminent speaker, Professor Robert Tleveler from USA, Phoenix.
Thank you, Professor El-Abadi, for all what you have said and for all what you are doing for Morocco, for neurosurgery in Morocco. I'm so delighted to introduce Professor Robert Tleveler, a giant of the neurosurgery known worldwide. Trying to summarize his curriculum in few minutes would be an illusion. Needless to say that Professor Tleveler is an honorary member of numerous surgical societies as the American Academy of Neurological Surgery, the American Association of Neurological Surgeons, the American College of Surgeons, the German Society of Neurological Surgery, and the North American Skull-Based Society. He is also honorary president of the WFNS. Professor Tleveler has been the founder of many theories on normal perfusion pressure breakthrough and the development of the famous grading system of arteriovenous malformations. He has also accomplished many surgical advances, particularly in the treatment of complex cerebrovascular lesions, and has developed many innovative surgical approaches for skull-based surgery. During his prolific career, Professor Tleveler has published more than 600 articles in referred journals, more than 200 books, chapters, and edited or co-authored multiple neurosurgical textbooks and atlases. Besides, he had won numerous awards and distinctions during his career as a resident in the 27th annual meeting of the Congress of Neurological Surgeons in 1977. He has had also the Eber or the Corona Award, considered as the Nobel Prize of Neurosurgery in 1999. He has also had the William Scoville Award in 2009, the Christian Medal in 2017, and the Glower Award in 2019. Despite his retirement 3 years ago, Professor Tleveler is still involved in teaching and education for new generation of neurosurgeons through many programs in the world. So on behalf of the Moroccan Society of Neurosurgery, I'd like to deeply thank Professor Tleveler for accepting to be with us today to teach us about the management of deep-seated cavernous malformations. Professor Tleveler, I thank you for accepting the invitation, and the atmosphere is yours. Thank you, Professor Tleveler.
Thank you very much for those over-the-top kind remarks. I want to say hello to all my African colleagues. I remember my visits to Morocco very well. It is such a beautiful country, and I sure hope that for the benefit of the world, the coronavirus pandemic passes relatively quickly. Can you see my screen?
Yes. Yes.
Yeah. So it's a pleasure to be talking about one of my favorite topics, which is really the management of difficult cavernous malformation. The beauty about cavernous malformations is that they really occur anywhere in the CNS system, whether it's in the spinal cord and the brain, and therefore they have challenged us to find routes to remove them. And so I have been fortunate enough to operate on well over 1,000 cavernous malformation, and over 500 brainstem cavernous malformations. And the goals of this presentation is just to briefly summarize what we know, the contraindications for surgery, the indications for surgery, some case presentations, and then sort of conclude with the safe entry zones. We have published extensively, and all of this is already within the literature and easy to look up. But I think one important aspect is that venous malformations, these things are in proximity and associated with cavernous malformations. Prevalence is listed here, symptomatic bleed. When you look at cavernous malformations that have been preceded with the bleed, and then they go forward, you have prospective bleeding. In the brainstem, the numbers have been as high as 60%. This came from a Japanese author. The problem with that is that once a patient is referred to a center like ours, and usually after having had maybe more than 1 or 2 bleeds, and then you take that cohort and you go backward and say, these patients have had so many bleeds, it is false because it's a very selected cohort. We've got to remember that surgery for brainstem cavernous malformation is not without risk. And here is what I think is a very good example of my own interpretation of the pathophysiology of cavernous malformation. You have a classic cavernous malformation sitting right here, and you have a large venous malformation, and this is the venous malformation, and here is the cavernous malformation. It is really part of that vein, very slow filling, and I think it's a budding of the venous system. When we talk about cavernous malformations, it is naturally very important to recognize when we don't have a large venous malformation. And this is the venous malformation, and here is the cavernous. I'm not sure why we're getting that back feed. Okay.
Professor Tleveler.
Yeah, now I'm unmuted. Are we okay? Fad?
It's okay. It's okay, yes.
Okay. So equally important is to know when not to operate. So if we have a patient with this kind of cavernous malformation below the floor of the fourth ventricle, and that patient has minimal or no symptoms, that patient should not be operated on. The patient and family will be very unhappy with us. A lot of patients were sent to me for surgery. So we did a prospective study for 2 years, and 87 patients with brainstem cavernous malformations were referred to us, and we recommended conservative management in almost half of them. These are patients that were sent for surgery, and we said almost half were not appropriate for surgery. And I think that is something that we have to remember. What are the indications for surgery? Lesions that are accessible, repeated hemorrhages, progressive deficit, significant mass effect, and a safe way to get to the cavernous malformation. There are so many different approaches to deep portions of the brain that I think we can't list them all, but I will give you some examples. I've said it 1,000 times, exposure is everything. Obviously, if we can see the lesion, we can manage the lesion. We have to preserve large abnormal veins because they carry blood from normal brain as well, and only take those that are really part of the cavernous malformation. Image guidance is essential. Monitoring is key. Sharp dissection. Obviously, microsurgery at its finest. EEG burst suppression because it increases the tolerance to temporary ischemia, and it makes the brain softer because you have decreased brain volume. Know your anatomy, avoid rigid retraction. And when we're in deep spaces, it may very well be appropriate to be using lighted bipolars or lighted sucker. so that we could see, because the light and the visual axis come in at different angles. We published not that long ago approaches to the thalamus, and as you can see here, we've divided them into 6 regions. Each one of those regions really has a different approach to get there safely. Image guidance. For deep lesions is absolutely essential, and using intraoperative image guidance makes it even better. So here's an example. Here you have a posterior cavernous malformation. Here is after a resection, but now what we're going to do is we're going to utilize the technology. The robotic function of the Zeiss microscope lines up with the entry point and the target point, and then we could just follow the guidance right to the cavernous malformation. This is just a little interhemispheric approach, contralateral. Makes it very simple to get out. Here we're using the lighted suction to help illuminate the cavity. And there's really no brain retraction. There are no retractors in place at all. And we take the little lesion out. And these are fine little special instruments that I've developed with Catalyst. And you can see the exposure, cut a little into the falx, no retractors in place at all. What do we do with this? It's decision making. This is a medical student, a young, beautiful female medical student, and she has had an apoplectic event. And this is what was discovered. So you really have options, observe or surgery. If surgery, what approach? Interhemispheric or below lamina terminalis? If interhemispheric, what position? Straight up or lateral? Well, she obviously selected surgery. This is her position. I like horizontal because you're using gravity, your eyes are horizontal, and your hands are horizontal. So it's the best to do complex surgery. So here we are, we're just going right to it. We see the cavernous malformation and we remove it piecemeal. Again, you see the lighted sucker to help us. The fine forceps with tiny little teeth on them to grab the tissue. And then we spend a lot of time inspecting the bed of the cavernous malformation so we can be sure we get everything out and not leave any small remnant behind. So you can see these, as you look around, it's not unusual to find portions of the cavernous malformation in the bed where the big cavernous malformation resided. And so we just keep going like this. And this is what it looked like, the small opening. And you can see cavernous malformation cavity, and it's completely gone. And she's had absolutely no change in her memory. Her exam is entirely normal. What do we do when we have a case like this? Intraventricular cavernous malformation that has spent a couple of times. Again, when we look at approach, you could go transcortical, perfectly reasonable, through the right frontal lobe. You could go interhemispheric, transcallosal, ipsilateral. It'll be difficult to get to this portion. Or you could go contralateral through the cingulus gyrus, which is a direct approach. Obviously, you can't really do that without image guidance. So here we are. That's the position we're going to use. Left brain is down. We're going to open the falx, and we're going to open it based on image guidance. So we make a little opening in the falx. Then based on image guidance, we make a little opening in the contralateral cingulate gyrus. And then we go right to the ventricle and we see the beautiful cavernous malformation. And then important naturally is to separate it from its small veins and not to lose it in the ventricle. And so through a very small opening, no retractors involved at all. This is all gravity on the contralateral hemisphere, and then nothing more than the small pathway through the cingulate gyrus to the cavernous malformation and ventricle. And there it is. And you can see the pathway that we took. So we're going to just go through a few approaches. Far lateral, very, very important because it's a way to get to the front of the brainstem and the medulla. And what we want to do is we want to take a case like this. This is a patient from London, England, and you can see that it's just at the bottom of the medulla sticking into. She's had 3 bleeds. Far lateral approach, easy approach. I use a paramedian incision. You can see the vein that's part of it. You can see the different colors, the fluorescent orange from different ages of her bleeds. But you can see with this exposure, you can really see beautifully on the bottom of the medulla. And then we dissect it out. You see the 11th nerve, and you see the different colors and then the cavity. There's the 11th nerve. She wrote a book about her experience, which is interesting because, and it's available on London, Amazon, because it shows us the perspective of the patient rather than just ours. Suboccipital Tleveler approach, again, a workhorse for those lesions that are near the floor of the fourth, but placed laterally. So here you have a classic example, a cavernous malformation that's sitting here. So we want to go through and get it out from this direction. Patient is prone. The anatomy, the importance of anatomy cannot be overemphasized. You can see the Tleveler junction. And what we want to do is this here. Feet are up here. Head is down here. So now what we're doing is we're exposing pica on the left side. We're opening the tela. And that gives us good exposure of the foramen of Luschke. And you can see that below, that's the middle cerebral peduncle. And then based on image guidance, we open and get right to the cavernous malformation. And again, no retractors. And again, the small instruments to allow us to remove this piecemeal. As opposed to the floor of the fourth, which is very, very eloquent, going laterally is very, very well tolerated. Gel foam is pulled out. I put in to stop any fluid from going down the fourth ventricle and aqueduct. And there's the postop. Retrosigmoid, another workhorse of an approach. Important naturally to go right along the transverse sigmoid junction. And again, no retractors required. So this is a patient with familial cavernous malformation, has been operated on before. And the one that is symptomatic now is this one. And so what we want to do is we want to come into the middle of the cavernous malformation, not here where it's closest to the surface, because we want to be equidistant in both directions. So we have the least amount of retraction once we're there, and then nicely to know when we're at the end of the cavernous malformation. So here we are, no retractors, small retrosigmoid exposure, 5th cranial nerve, and then we just keep walking up. We keep walking up until we're going right down the middle of the cavernous malformation. So that's brainstem. It's just above the 5th nerve. And that way we get right to where we want to go. No retractors, right into the middle of the cavernous malformation. And this is a large cavernous malformation. So it requires a lot of resection and portions, and I felt like it was growing while I was taking it out because there was so much in it. But we keep going until we really get it all out. And here it is post-op. You can see the empty cavity. Hearing was still intact, and there was no change in the motor exam. I'm not going to show this one. I wanted to emphasize opening the petrosal fissure, but we're going to go on to the supracerebellar infratentorial approach. The beauty of that approach is really you can go from the midline all the way over to the retrosigmoid approach. So if we have a lesion like this, where we have cerebellum here, we have temporal lobe here, this is the tentorium. This is a direct shot to the lesion. And so this is what we do. This is transverse sinus, that's cerebellum. We're going down to the ambient cistern. That's the superior cerebellar, fourth nerve we saw. And without a retractor in place, that's just a patty being held over by the sucker, we get directly to the cavernous malformation and take it out piecemeal. And we're done. And here's what it looks like. This was our entry point right here to that lesion, empty cavity. She got worse some and then improved back to baseline. How much can you take out through this approach? This is a patient from Copenhagen, a young girl, 15 years old. You can see the cavernous malformation occupies the entire third ventricle, extends up to the foramen of Monroe. And this is what we did. Again, that's the sinus, tentorium, cutting the tentorium to gain access to be able to go up. Ambient cistern over here. We identified the best projection based on image guidance. And then we just opened through the midbrain and we start taking it out. And we keep taking it out. We're using a little laser and we just keep taking it out piece and piece after piece. And then again, inspecting the bed. And here you can see we're at the end of our resection. And this is what it looks like afterwards. Empty cavity. And this young girl went home a week later. Orbitozygomatic approach, naturally, everybody is comfortable with that. And I want to show you just one case. And this is a 28-year-old. She's had 3 hemorrhages, and she has this cavernous malformation. Problem is, how are you going to get there? You can't really come this way because the peduncle is in your way. So you have to come contralateral. And that's what we're going to do here. We're opening on the right side. In this case, we're going between the internal carotid artery and the optic nerve because it's the best angle. We get down to the interpeduncular fossa. We separate all the tiny little vessels until we see the contralateral peduncle, and then open after checking to make sure we're accurate with image guidance, and we find the cavernous malformation. And again, with these tiny little pituitary-like instruments, you're working between the optic nerve and the internal carotid artery. And here we saw it coming in from this side, and there's the empty cavity. She did remarkably well. Transcallosal approach, it's really a workhorse for many, many lesions. And again, I like the horizontal position. Here's a gentleman with one in the third ventricle attached to the roof of the third ventricle. So again, horizontal position. I like to take the dura and tack it to the bone so it actually moves the sagittal sinus just a little bit. It's not in the way. Coming down to the corpus callosum. We see foramen of Monroe. I like to go lateral to the choroid plexus rather than medial as it's described in many textbooks, because it means that you have the choroid plexus to use to protect the fornix. One more layer to protect the fornix. Now we're in the third ventricle, and we're looking at the cavernous malformation. And then I'm separating it from the roof of the third ventricle. In this case, I'm using the little CO2 laser to retract and cut. And the last remnant, and here it comes. You can see again, no retractors in place, just utilizing gravity. And here's the post-op, the lesion is gone. More difficult is this one, which is in the posterior portion of the third ventricle, extending into the aqueduct. Here you can see how far it extends from the third ventricle into the aqueduct. But the same sort of approach we're going to use, same approach. Now we're inside the third ventricle. That's the entrance into the aqueduct, the back end of the third ventricle. And so utilizing, again, very small instruments, the lighted sucker to help illuminate. Here I am using a retractor to hold over the corpus callosum. And we just keep removing it. And again, making sure that we get every little remnant out. And so here we have pre-op, post-op, pre-op, post-op. Last case I want to show you is this cavernous malformation in a little 6-year-old. He'd been operated in his home country. They had to stop after 16 hours because of severe blood loss. They did not get a diagnosis. It was attempted in another city in Houston in the United States. They also had to stop because of extensive blood loss. And this is what it looked like. Giant lesion, but this one naturally is inside the transverse sinus. And those are entirely different animals. They are very, very bloody as opposed to most of them. So here you see where the end of the sinus is. That's the cavernous malformation in here. And Dr. Albuquerque was able to find one tiny little vessel, and he injected this much onyx into the cavernous malformation. That's worth at least 3 Mercedes-Benz. And so here, the first thing I did was make it much larger, get control over the sinus on one end and cut the tentorium, do the same thing on the other side, and then it was easy to remove. Because of the onyx, you can see the sparking from the cautery. I never use cautery except in this case. And you just see it coming out. It really is not difficult at all at this stage. And here's one side of the sinus and the other side of the sinus, empty cavity. That's him, that's his beautiful Italian mother. And I was very disappointed that she kissed him instead of me. And this is 1-year follow-up, excellent student, excellent athlete. And then I was able to get 9-year follow-up just very recently, pre-op, post-op, and he's just a terrific student and athlete. So these here are the entry zones that we feel are safe, relatively safe, that can get us to a myriad of these lesions. So we were really very pleased with how we were able to develop these approaches to virtually every aspect of the brainstem. All these approaches are available. These are the two atlases we've put out recently that have each and every one of those cases in them. So the current management, I've wanted to say, is when and when not to operate. The resection of symptomatic and accessible lesions is reasonable. Anatomy cannot be oversized, but good exposure allows resection of virtually all cavernous malformations when they are appropriately selected. Image guidance, minimal retraction is essential. All of these approaches are based on knowledge of anatomy and function. I thank you very much for your attention.
Thank you, Professor Robert Spitzler, for this wonderful, amazing talk, overview of all the approaches, very challenging approaches, and for many research about this deep-seated brain cavernous malformation. And I really appreciate very much the last cases we had. Published one case is about boys, also about 4 or 5 years. But your challenge is of course, the lateral sinus was invited in our cases, not. So we are more lucky than you. Thank you so much for this wonderful and phenomenal talk. So if you allow me to introduce the second speaker, and then we will have the question at the end. If you are you can stay with us.
Najia, I have to go because I have another appointment. I really apologize.
So we will have our discussion now, and then we will have the two other speakers. So Professor Benzegmoud, you can please.
Okay. Thank you, Professor Spitzler, for this outstanding presentation, as usual, in which you emphasize the surgical indications as well as the surgical approaches for each deep location of cavernous malformation. Allow me to ask you 3 questions. The first is about does the age of the patients influence your surgical indication or not? And the second question is regarding the cases of cavernomatosis. Apart from bleeding from one or plus cavernomas, in which cases you advocate surgery in cavernomatosis? And the third and last question is about the indication of radiosurgery in such deep located cavernous malformation. Thank you.
Very simple. Age naturally makes a difference about whether you operate on somebody. They have to have a life expectancy that is favorable in relationship to the risk of surgery. So somebody that is 80 years old with a brainstem cavernous malformation is going to be treated entirely different than the little boy I showed last when you're 7 years old. As far as moldable familial cavernous malformations are concerned, we have quite a few families that we followed. They do bleed, and we would treat only the symptomatic ones or the ones that are growing and causing symptoms. And then finally, the last question was radiosurgery and cavernous malformations. I really don't think there's an indication for radiosurgery for cavernous malformation. They're venous lesions. Radiosurgery is the least effective on veins. And when you have a cavernous malformation in an eloquent area, the risk of radiosurgery far exceeds the risk of surgery.
Okay, thank you.
May I ask a question, or maybe?
Yeah, sure. Please, Professor Abdel. Professor Labadi, you want to ask a question?
May I ask a question, Professor?
I'm afraid her connection is not good.
Yeah.
It's about, yeah, but okay. So my question is about when you have usually we have more frequently the abnormality, the development of venous in the deep seated, especially in the brainstem, and very difficult to coagulate in the, as you know very well, more than us, coagulate in this very functional area. So sometimes, what do you advise us to how to deal with this venous without coagulate it?
Well, first of all, I used to say you never coagulate in the brainstem, and I was completely wrong, because stopping the bleeding is more important than worrying about that you're going to affect something. With fine bipolars, it is not very risky. But the main thing with cavernous malformations is to remember that even though you can have profuse bleeding, it is venous bleeding, and a little bit of tamponade in patients will always take care of it. You know, I feel badly for the other speakers, so I think we should move along and have the next speaker. I don't want to take up all your time. I thank you again. It was a privilege to be here. Look forward to the next one.
Thank you so much. There is another question. Maybe the last question before to move to the second. No. Okay.
All
so
right.
you are very clear, and thank you so much.
You're welcome. You have a good meeting.
Thank you. So we will move to the second speakers. It's Professor Martin Sam. He's a close friend of me and chairman of the Department of Neurosurgery. Dear Martin, it was a great pleasure for me to meet you last November during the fantastic winter neurovascular meeting brilliantly organized by our friend Professor Fadi Charbel in Steamboat, Colorado. Let me introduce you to the participants. Professor Sam Martin is the chairman of the Department of Neurosurgery, Masaryk Hospital, University on Perinch, Usti Anad Labem. Sorry for my pronunciation for this, because it's a little bit difficult for me. It's from Czech Republic, where he succeeded as head of department to Professor Benes since 1997. He had many professional stay in neurosurgical departments in some university hospital in Europe, like Vienna, London, in many medical centers in USA, among others, Phoenix. Maybe you were with Professor Tleveler. And of course, in many neurosurgical departments in Japan, Tokyo, Nagasaki, etc. Outstanding. He organized several outstanding courses, not only for the European Association of Neurological Surgeons between 1992 to 1986, but also 16 neurosurgical, vascular, and skull-based courses in USA, Europe, focused on surgery and endovascular treatment of the cerebral aneurysms, EVM, cerebral ischemia, but also he established since 2004 a clinical and educational skull-based center and a center for facial nerve surgery, considered as WFNS Education Center Class A. Great researcher in several fields, especially in cranial and peripheral nerves regeneration, anatomical skull-based dissection since 1999, institution of anatomical skull-based laboratory, the first in the Republic Czech. He participated to many international trials, such as a stick, for example, and of course he have published more than 100 paper publication, 14 articles in the books and monographies, invited speaker more than 130 lectures. He was the president of Republic Czech of Neurosurgical Society between 2014 to 2018, and currently vice president of their society. He also served in many positions in European Association of Neurosurgical Society, WFNS Skull-Based Surgery Committee, Education Center Class A, as already said, Secretary of the Central European Neurosurgical Society, welcome again, and thank you for accepting our invitation and sharing your huge experience in this field, which aneurysms are indicated for clipping today. Thank you, Martin. Go ahead. Thank you.
You should unmute yourself.
Oh.
Is it visible, my presentation?
Not yet.
Not yet.
Yes.
Yes?
Not yet. Not yet.
Can you share it again?
Okay.
It's okay. Oh,
Good.
great.
Okay. So thank you again for invitation, and I would like to speak about indication for aneurysm surgery. And we know that we have two big international randomized studies, ISAT and BRAT, and now we have long-term results also. And we see that after 10 years, we have now BRAT after 10 years, that obliteration rate after coiling is only 22%. And retreatment, it's very high, it's 19%. So I think it's a new situation, best after 2002, after ISAT publication. And now the surgeons, they have more power because the retreatment after coiling is very high and surgeons should be more active. And here we have a very elegant validation system how we can predict recanalization. And it's a very easy scale. So we see for the aneurysm specific factor is a aneurysm size, ruptured or unruptured. And then we see treatment factors, coiling or stent. And then how is the initial treatment results? If the complete Raymond-Roy 1 or second class, if there is a remnant of the neck, or Raymond 3, where is a remnant in the aneurysm. So it's very elegant scale. And if we have case, for instance, aneurysm 10 centimeter large, it's 2 points, it's ruptured, it's 4 points, only coils, and Raymond-Roy 1, it means that neck is open. So we have a 0.5, and it means that the patient has a 73% of the recanalization rate. It's very high. So large aneurysm, wide neck, we should prefer the clipping. Here we have one of our algorithms. It's very clear. So for coil, we prefer old people, posterior circulation. And for clip, we have aneurysm with hematoma, of course. Then we have symptomatic aneurysms with a compression of the third nerve, young patients, and the giant aneurysm. And I would like to add more boxes. So we will speak about 5 indications for where surgery is preferable for this indication. So first is large aneurysm. Especially in this case, I will show is a large ophthalmic aneurysm with compression of the pathway. So there is some deficit of the optic nerve. So this case is a large aneurysm ophthalmic. You can see the fetal type of the PCOM, so there is no collateralization. You can see the PCOM fetal type. And we did a balloon occlusion test, and there is no collateralization. So the balloon occlusion test was positive. So we have no collateralization. So we decided for this strategy. First, to do prophylactic bypass, classical STA-MM4 bypass for prophylaxis for the ischemia. And then we clamp the carotid on the neck, and then we use a tandem fenestrated clip. So short video, you can see the drilling intradurally the clinoid process to see the ophthalmic artery. Then we prepare STA. This is a donor for our prophylactic bypass. Now we control the cut flow. This is the irrigation. And now we use the acceptor. We prefer always the temporal lobe. There is less eloquency for the bypass. And now the bypass is done, so we are prepared for clipping. So this is a huge aneurysm ophthalmic. You can see carotid, you can see the A1, M1, and now we clip carotid on the neck, and we hesitated if we should suck the blood from the neck or not, but it's not necessary. You can see it's possible to put first fenestrated clip and positioning in the center, and we create a new lumen with this fenestrated clip, but we plan do more than two. So we plan 3 clips, fenestrated clips, for complete clipping of the aneurysm. Here you can see fetal type of PCOM, so we insert a second fenestrated clip to be sure that there is no remnant, and the last clip is on the proximal part of the carotid, and now we exclude completely the aneurysm. You can see the ophthalmic TCD controlled ophthalmic aneurysm, and now we see the situation. PCOM is okay. Very important now, it's control the choroidal artery. So we use the ICG. It's very elegantly, you can see that the choroidal artery is patent. So prophylactic bypass, aneurysm clipping with fenestrated clip, and good result. So we can conclude large aneurysm with compression of the optic pathways. We prefer surgery because we decompress the optic nerve and results are good. Of course, we can use flow diverters today. It's very popular, but we should be aware that this type of aneurysm, it's not suitable for the flow diversion. It's a A type, when aneurysm is arising from the fundus, and the second C type, when the ophthalmic artery goes from the inner curve of the carotid. So the 2 types are very dangerous because there is a problem of the retinal emboli or ischemic atrophy of the area of ophthalmic. The second article, also very important for the flow diverters. You can see the visual symptoms in this series. 90% not improved vision. So surgery is more efficient because you directly decompress the optic pathways, and the results for the visual outcomes are better. So this is a large aneurysm. Second box, second indications, the perforator arising from the neck. It's also very important indication. You can see choroidal artery is going from the neck. So it's very nicely visible. This is really neck. And our option is coiling, but we don't prefer coiling here because Raymond Roy will be the class 2, because you should leave the neck open and there is a high number of recanalization. So we prefer clipping. And we choose the bar fenestrated clip. And big advantage of the surgery is monitoring. During surgery, we can adjust the clip perfectly on the neck and also control MEP. So we control motoric potentials, and we are sure that we are doing everything under control. So after surgery, nice clip, no remnant, and patient is good. Second case in this indication is large choroidal artery aneurysm. You can see balloon occlusion test is tolerated, so the carotid has good collateralization. So we decided for surgery because flow diverter brings 7% of the occlusion risk of the choroidal artery. So now we see a huge aneurysm on the lateral position, and very important, the basic step for this huge aneurysm is that we should deliberate the choroidal artery from the fundus. Why? Because after clipping, you can kink the artery. So it's very important to deliberate choroidal artery within all the course of the fundus. And when the choroidal artery is free, then we can start with clipping. Very important point. And now we put proximal control. Now the second clip on the carotid, distal. And here we are very happy because the choroidal artery is arising from the carotid. So this is, we are very lucky because now we have collateral flow and the temporary clipping, it's not dangerous. Now in this moment, we put the injection and suction blood from aneurysm. It's not visible, but you can see the situation much more relaxed. So blood is aspirated. And now we can see choroidal artery, neck, and situation. Now it's very easy. We put the clip on the neck and choroidal artery is perfectly free. So you can see that clipping, we control PCOM, we control choroidal artery, and everything clear and good results. No remnant, and we see here the PCOM preserved, choroidal artery preserved. It's good. So how is the literature? Endovascular coil for these aneurysms are dangerous. You can see 2 articles, and morbidity and mortality 10%, and all morbidity is in the case when the choroidal artery is arising from the neck. So for this, the case is better surgery. Comparative study, very small numbers, but the same recommendation. You can see that clipping, you can clip any aneurysm, but for coiling, not this aneurysm with the choroidal artery from the neck. So we have a second indication. Flow diverter, of course, it's possible, but we know about 7% of the risk of occlusion choroidal artery. And also there is a problem of the 3% and 5% and 3.5. It's delayed ischemic deficit after finishing of anti-aggregation, dual anti-aggregation. So flow diverter is possible, but it brings risk of the obliteration as also ischemic deficit. So this is our second box. The third box is a wide neck. It's very known that the recanalization of wide neck is very high. I show you 2 cases. It's a very wide neck on the ACOM aneurysm. Coiling, it's not possible. You can use the Y stand, but it brings high risk of the complication. So we recommend in this case fenestrated clip. Again, we did 3 fenestrated clip, and we preserve all the Heubners, both A2, and these clips are very useful for this complex necks. We use also ICG to control or vessels. TCD is the first choice, and then we use ICG. So you can solve this aneurysm with the wide neck very elegantly with good results. The second wide neck is a superior cerebral artery aneurysm. You can see wide neck, coiling, very dangerous because you should leave the remnant and recanalization. Flow diverter, it's not possible in this case. So we decided for surgery. It's a subtemporal approach. You can see fourth nerve, and we are very lucky because the direction of the fundus is superiorly, so you can see nicely the neck, you can see perforators, and we use the temporary clip of the basilar, and then we put definitive clip on the neck. You can see now we adjust the perfect position of the clip, and yeah, it's done. So we preserve SCA, no remnant, and elegant solution. Fourth box, and also well known, is MCA aneurysm. MCA aneurysm, we should also prefer surgery because it's good after opening, good approach after opening Sylvian fissure. You can see very wide neck, also very high recanalization rate. And in this special case, we use multiple stacked clipping, which is also very efficient, and you can preserve all perforators, all M2, both M2 and clipping without any remnants. And second case, the large MCA aneurysm, it's a big chapter. And in this cases, we combine the approaches, bypasses also. So in this case, we use the STA bypass for preservation M2, temporary M2 segment, and the second frontal root M2 we created by clip. So after surgery, good bypass functioning and good results. And we can see also the long-term results of the MCA aneurysm. You can see Brad study of the Tleveler, rebleeding, 0, Rodriguez, Hernandez also, they prefer clips for the MCA aneurysm, rebleeding 0. And opposite Mortimer, it was policy the first coil for the MCA aneurysm, and they had 3 deaths from rebleeding. So this is evidence for surgery for MCA aneurysm. And last box, the 5th is age. We know that ISAT study after 5 years, they published that ISAT is very good for patients in the short follow-up in 1 year. It's preferable for coiling, but after 5 years, you can see the results that the advantage of the coil embolization cannot be assumed for patients younger than 40 years. So patients younger than 40 years should be generally indicated for surgery, not for endovascular technique. And also long-term follow-up after ISAT 18 years follow-up, and you can see that rebleeding is significantly higher for endovascular treatment. So when we summarized this, we can see that we have long-term results in the ISAT, BRAT, California study, it's unruptured aneurysm, and all studies say the same. Lower invasivity of the coil in the short term are compensated by lower obliteration rate and higher retreatment. So all the studies show us that after 7-10 years, there is a high number of retreatment, 19% for coil, and only not 1% for clipping. So for the long-term results are much more better results for the surgery. In my country, it's interesting, we have now 50-50 coiling and clipping. After ISAT, it was majority cases was on the endovascular, but when we see the ISAT follow-up long-term California, but so now the situation in our country is in a balanced 50% to 50. So this is a summary, most important 5 indications groups for surgery: young patients, giant aneurysm, perforated from the neck, wide neck, and MCA aneurysm. And for each center should be individual approach, of course. We have trials, but we have our common sense, and we should be friends with endovascular people, and we should not fight, but we should cooperate. And we should know results on this aneurysm on coiling, on clipping, and always we should choose the best solution for the patients, most easiest solution, and most efficient. So in this years, and we have now long-term results of trials, I think that the surgeons should be more active, because I feel that the technology, power of technology of the endovascular treatment and coiling now is a 50-50. So in my center is about 60% we clip and 40% we do endovascular. So now we have a background, we have good results of the long-term studies, and we can be active and we can cooperate with the endovascular people very, very fairly. Thank you. Thank you for your attention.
Thank you very much, dear Sam, for this wonderful and nice talk, and really very wise, because we know today many teams there is fighting about the aneurysm, and you are right, we need to collaborate together and not fighting about patient.
Exactly.
We choose the best, as you said judiciously, the best treatment for our patients together. And sure, I totally agree with you that we we noticed that more and more with the follow-up, there is more rebleeding with the coils than, of course, clipping. So we will have this discussion just after the third talk. We have with us endovascular doctors. So we leave the question at the end, if you allow me that. Thank you.
Okay, thank
So
you.
the last speaker is my friend, Professor Abdsamad Al-Azhari. His reputation is well established. He is known both nationally, where he has worked tirelessly for the development of Moroccan neurosurgery, and internationally. As an example, I can present him as one of the founder member of the Maghrebian Federation of Neurosurgery, the African Federation of Neurological Societies, and the African Federation of Neurosurgery, of which he is still president till now. So I really got to know Abdsamad in 2005 at the World Congress in Marrakesh, and during this same Congress, where we collaborated enormously. From this collaboration, of which I am very proud, a great friendship was born, which has united us since. So Abdsamad, in parallel to his remarkable academic career at the head of one of the largest neurosurgery departments in Morocco, in Casablanca, since 1999. After his retirement from the public sector, he was appointed chairman of neurosurgery training program and referent in University Mohammed V Hospital, Sheikh Khalifa in Casablanca. He is also chairman of surgery of the department in the same university. He was a former president of Moroccan Society, president of the Maghrebian Federation, and honorary president of CANS, African Association of Neurological Societies. He has organized many successful congresses with a great success, and the most recent that of the French-speaking Society of Neurosurgery, of which he is currently the secretary. So it is with a great pleasure that we also learned in 2017 of his consecration by the WFNS, by receiving the WFNS Medal of Honor for Education. And this consecration testifies to his scientific contribution, his commitment, and his leadership, which without doubt contributes to the influence of the image of Morocco, of the Maghreb and Africa on the international surgical scene, which also earned him to join the prestigious circle of the World Academy of Neurological Surgery. Please, he will talk today about aneurysm, of course, one of his favorite fields, aneurysm surgery, between what we expected and what we find. Please, Abdsamad, thank you. Fed? Professor Azhari, are you
hear us?
Yes.
Please.
Fed, could you help me, please?
Will you share your? You
Yeah.
can share your screen. If you want.
Okay. You can share it now?
Yes, yes.
So, can I start?
We still don't see your presentation. So
Partager. Partager à droite, c'est ça? En haut à droite?
oui, partager l'écran, c'est en bas.
Ah, c'est en bas.
Oui, c'est en vert.
Voilà. It's okay now?
Yes, you can go full screen once.
Okay, thank you, Najia. And Thank you, Najia, and I will thank the Moroccan Society of Neurosurgery, Professor Khadra, and all the team of the society and the panelists. And thanks, Fahd, for the organization of this very beautiful webinar. I think it was very interesting to share some tricks and some surgery problem with the colleagues, and the title I was inspired by Professor Najia, who told me that I have to talk about some things which relate to experience and the problem and all the problems of this surgery. So I thought that to expand and what to find was really very important for vascular neurosurgeon and for young neurosurgeon. That is the team which I worked a lot before in CHU Casablanca, Ibn Rushd, and that is a new team in university, UMC's university. And just for the memory, little thought on friendship for neurosurgeon worked in CHU de Casablanca, and especially for Dr. Bouchareb, Dr. Sami, and Professor Yaqoubi, and also for Dr. Aziz and Dr. Bouzou. They was before me in the department. And that is the all head of departments in neurosurgery in Morocco around our mentor, Professor Khamlichi. Despite the contribution of anatomists and neurosurgeon, our knowledge of neurovascular system seems incomplete. We also need to familiarize ourselves with different configuration and the anomaly of this surgery. This surgery is like surgery of Sella, just in one difference: in aneurysm, it's vascular disease, and vessels are abnormally fragile. As you see here, for example, if you see here for this craniopharyngioma, we can tract the E1 and E2, no problem. And for this meningioma, for example, is the same problem. There is no vessels disease. But in aneurysm, if you look, if this aneurysm of anterior communicating, you see the aneurysm is here, is very fragile, and there is some problem with these vessels in the anterior communicating artery. It was reported by Wilson, 85% of the aneurysm of the anterior communicating artery were associated with hypoplasia, which was related by other authors. And this abnormality was described also by Yazargil in 1984. And in our series, there is some cases, but like this case, which the anterior arterial communication was fenestrated, and the aneurysm was on the anterior of this artery, and was clipped without problem after dissection. Sometimes what we expect, we find it. Like here for this aneurysm of bifurcation, and sometimes it's difficult to find what we expect, as you see in this case, because we can see the aneurysm, which is very complex, but all the arteries around and the perforator arteries aren't visible. What we have only our anatomy knowledge, and before any surgery, many questions we can have. How I am going to approach it? How will have cerebral parenchyma behave? How to get a good brain relaxation? What condition are the vessels in? In what extent will my anatomical knowledge serve me to understand the configuration of the aneurysm? Are the angiography and angioscan sufficient? And what stressed situation I'm going to face? That is the question really very important for every operation. So we use our knowledge and imagine for one goal: clip the collar while preserving the brain. So what we have, from theoretical anatomy to angiography, we have to transport the angiography in the anatomy. And from the angiography, we have to imagine and to read all the images in order to have good dissection and to have very clear and very precise anatomy to understand the configuration of the and finally to clip. Sometimes there is idea about correlation between angio and surgery. Like here, for example, as you see, if you take any books, you have this picture, and the arteriography, angiography, you have this aneurysm in 3D, and in reality, we get the same image, and the clip was placed in the right position, confirmed by endoscopy that the place is the right place. Now we have to imagine the anatomy only with one tool. It's angiography. We have our knowledge, we have our anatomy, and in this case, the books of Roton are very nice, but it's very difficult to use it and to think about it in neurosurgery. We just to keep it in mind and to go to angiography and to go to surgery. Is there some future in this technique? Some software could help. For example, here there is a software. Some software are developed, but only for the vessels, and no information about brain structure. And if you go to the simulation and to the tree navigation, it's not the operation room. So you have to come to the earth and to go to operation room with knowledge, also to know the anatomy of cisterna, which are sometimes very complicated, as you see here. The hemorrhage leads to stain and thickening of the arachnoid, making visualization of structure and the dissection more difficult, as you see here in this video. So anim surgery needs good angiography and good material. That is very important. And the success of surgery and the association of morbidity and mortality depends on the technical difficulties during the procedure, the proximity of the lesion to the vital structures, perforators, arteries, probability of rupture during handling, and the occlusion of aneurysm. The strategy is to make an itinerary to dissect the cistern, which are separated by trabeculation, but the cistern are modified by the hemorrhage. The first step is to identify all the arteries in the field, as you see here, and the most difficult and dangerous is to detach them from the bag or the collar, especially when the aneurysm is down and back. The anatomy of area away from aneurysm seems normal. For example, in this case, is aneurysm or is MCA aneurysm, as you see here. And if you see the anatomy before, because what we do, we make dissection of the carotid and go to the MCA. That's what we do. And if you see here, for example, the anatomy is good before the malformation. We see the carotid, the optic nerve, the posterior communicating artery, the choroidal artery, and the third nerve. And it's when you go to the malformation, the anatomy is really different, and the dissection is more difficult. The key of the dissection of aneurysm is the separation from the adjacent arteries and the recognition of the arachnoid layer to cut it sharply and gently. For some examples, I would show you for this example. In carotid, it's different. It's different from the MCA and from the anterior communicating artery. It seems more simple. As you see here, we just, without artery, we visualize the carotid, the collar, to put preparation for the clip and to put the clip, and it's really different from the communicating artery. As you see here in the video, it's the same pictures. As you see here, some dissection, simple dissection, as you see here, and to put the clip in the right place. Second case of carotid artery, we can imagine it's just near the posterior communicating artery, as it's the same, really the same technique, and no problem with putting a clip in the same place, because the dissection, even if here, for example, there is some thick arachnoid. For the communicating, the anterior communicating artery aneurysm is really different. As you see in this case, you can't read everything in this angiography, but in 3D you can see that the aneurysm is between E1 and E2, and it was failed in endovascular, and we decide to operate it and to put the clip on the neck of the aneurysm. If you see here, it wasn't very easy because there is many dissection to do, as you see here, and to cut some trabeculation, some arachnoid, and to have at the end the aneurysm, and to put the clip in the right communication. And you see here the ulnar artery. Another case, as you see here, it's a complex aneurysm. It's the projection is anterior and superior. The dissection was very difficult because there is a lot of trabeculation, and at the end we success to have to put a clip in the right position. As you see here, that is the dissection, millimeter by millimeter, to cut everything, and to go to the gyrus rectus, and to make a small resection in the gyrus rectus, because the sac was buried in the gyrus rectus, and at the end the dissection of all on perforating artery, and to put the clip in the right position, gently, and at the end we have the clip in good position, and we cut the sac. Another one different, as you see here, it's in the community, but I showed this picture before. The artery is really very dysplasic, and the aneurysm was very fragile, and in posterior area. This video is not for the MCA aneurysm. It's really different. Sometimes you expect, for example, in this case, it's M1 aneurysm, but you don't expect some things which we have. It's when dissect the carotid, we find 6 arteries from the recurrent of the carotid. It was, where is the posterior communicating artery, and where is the anterior choroidal artery? I don't know. But when arriving to the aneurysm, it was more easy to clip this aneurysm. But if you see this video, you see that 6 arteries from the carotid, and going to the M1, we just see the color here, and to put a clip in the good position. For this the giant aneurysm of Sylvian bifurcation, as you see here, there is some area fragile, and when we operate it, we don't expect this. The artery, there is some atheroma, the artery is fragile here, and there is atheroma. We dissect the sac, we put the clip on the collar, and we dissect the perforator artery from the sac, and at the end we put the sac and the screen with bipolar, and the operation was good. If you see this dissection, as you see here, it was very difficult to dissect. The first one save is to put the clip on the collar or on the sac, because it was very fragile with atheroma, and to continue the dissection and to take away the arteries and the perforators, as you see here, and at the end to have a clip in the right position and to coagulate it and to have good visualization of the perforator and are safe. For the MC arteries, like here, for example, look at this complex aneurysm. I don't expect that the sac was attached. This sac was attached to the clinoid, as you see here, and after dissection, there was a rupture. There was a rupture, and we put a sac. We put a clip on the sac. We detach the sac from. Sorry. We detached the sac from the clinoid. It was really very easy, and to coagulate the sac, and to finally to have the clip on the collar in the right position. This case was really very difficult because there was two aneurysms, giant and one small, and where it was expected the rupture is big aneurysm. But if you look at this expectation, we have this aneurysm with the baby aneurysm here, and with this sac, no problem. After dissection, we have the sac of the giant aneurysm, but look what happened. The first clip go away because there is a lot of pressure, and the second clip go away also, and the third clip was right. So I thought that it was finished. We take off the two clips. We just try to see the perforator because there is one here. It's not under the clip, and another one here. And the clip was in the right position in the collar of the aneurysm. But after I want to save the intervention, but rupture of the small aneurysm happened, and we try to put one small clip on just on the small aneurysm, and it was finished, but it was really very very big surprise. The main goal is to put a clip on the collar, as you see here, and to see and to preserve all the perforator artery, and to put the clip in the collar in the right position without any damage of the brain, as you see here. In Casablanca, we recorded. We have about more than 200 movies or video of intervention. Before we didn't do that, and since 2009, there is no movie, and I think in the future it's very important to record every operation and every aneurysm to have lessons for that. In conclusion, could we expect the difficulties even if the technique is mastering? No. My answer is no. Are the difficulties related to the neurosurgeon and to the patient? It's both, because it depends of the neurosurgeon, but it depends also of the patient, of the projection of the aneurysm, of the fragility of the arteries, and for the size of the aneurysm. The difficult to find what we expect some location like anterior communicating artery and then say aneurysm, but also in carotid-ophthalmic. I haven't the time to show you some difficulties for the carotid-ophthalmic aneurysm, because their projection are sometimes under the optic nerve or inferior, and it's difficult to see the color. That is the seminar we organized in French-speaking meeting. I participated in Abuja with the colleagues, with Yuko Kato and our colleagues, you know them here, to this meeting and to this seminar. Here it's a seminar in Rabat organized by Professor Wahabi, and here and with Professor Najia Abadi, with our colleague Japanese and Chinese. And that is the committee of the vascular in WFNS with my colleagues, but we don't work together. I hope we will work together in order to collect all the information, complication, and every tricks and pitfall about this surgery. That is a neurosurgeon which was educated in CHU de Casablanca Ibn Rushd, and that is the repartition in Morocco and also in Africa. And I will thank everybody for the participation of this surgery, and thank you very much.
Thank you, dear Abd Samad, for this wonderful and nice presentation and sharing your very important experience with all our colleagues, especially many take-home message about tricks and tips of this type of surgery. And we know all of us that you are one of the fan of the vascular surgery, and your talk today indicate that you are very passionate by this. Thank you. Thank you.
The mute.
Before starting the discussion, I have just to introduce. Yeah, please. May continue, Faye? There is a problem?
No problem.
So, okay, it is always with a lot of nostalgia, I said, an emotion that invite me each time this hospital group is evoked, because I spent 1 year there in 1991. At the time there was 2 separate departments, the PTA department with Professor Fouano and the Salpêtrière. Today, I think you are very lucky, Professor Clarençon, to work in this beautiful building named the Babinski Pavilion, aren't you? Professor Clarençon does research on many vascular fields such as brain EVM, segmentation algorithm, angiogenesis study, and mechanical thrombectomy. He also works on spinal cord vascular malformation to improve diagnosis tool. Maybe you kindly give us some word about it. I don't understand EI, CTR, 4D, etc., and as well as endovascular treatment strategies. He is author of many publications, such as one of the latest I appreciate very much during this health crisis, intracranial hemorrhage related to brain vascular disease and COVID-19 containment. Where are the patients? Sure, there are a lot of patients, I think, didn't access to the hospitals during this COVID-19. He collaborates in one of the greatest vascular team in France with Professor Philippe Cornu, the neurosurgeon of this team. They work harmoniously and collegially for the care of patients suffering from vascular pathologies. And we are happy today that he accepted our invitation to share with us their experience. The third panelist, and the last one, is also have the pleasure to introduce him, is Professor Mbaye Thioub from Dakar, Senegal. He is a professor of neurosurgery. He works as neurosurgeon at the Central Hospital of Fan in Dakar since 2014 and became professor in 2018. It was strongly recommended by my friend, one of the leaders in Senegal and in Africa in neurosurgery, Professor Bokar Saïdou Badian. He was with us in the beginning of the webinar, but he apologized because he had something to do urgently. By good luck, I attended and I listened to his conference during a recent webinar talking about the Senegalese experience of aneurysm surgery of remarkable quality, and which I personally greatly appreciate. Clermont-Ferrand in France between 2011-2013 and has obtained his university diploma in vascular neurosurgery in 2019 in the University of Lyon 1 in France. Welcome again, and thank to be among us, Professor Thioub. So I may ask Professor Belzegmo to lead this discussion. Thank you.
Yeah, thank you, Professor Abadi. I wonder if the other colleagues in the panelists, especially the endovascular Professor Frederick Clarensen, has a comment on both intervention about aneurysm, cerebral aneurysm surgery. Clarensen,
a couple of comments. Indeed, I am the only interventional neuroradiologist in the panelists, so
yeah,
nobody's perfect. Sorry. I have some comment. I agree that with the fact that localization is a big issue, but I think we have to distinguish two case scenarios: the ruptured and unruptured aneurysm. In unruptured aneurysm, localization is not a big deal because the risk of rupture is very low. In previously ruptured aneurysm, localization is a big issue, and we have to be aggressive and to have a complete occlusion. So I think we have to distinguish these two case scenarios. And I agree with what has been said that in compressive carotid ophthalmic aneurysm, endovascular treatment sometimes are not efficient because we cannot relieve the compression on the optic pathway. So in these specific cases, surgery I think is a good option. But for other cases of carotid ophthalmic aneurysm, we are doing a lot of flow diverter stent, and we have now a lot of experience. And I think it's very good. It's a very nice tool. And even when we cover the anterior choroidal artery, it's very rare to have an occlusion of the anterior choroidal artery. And usually it's a progressive occlusion, and you have some collaterals, and so you have no symptoms. And I covered a lot of anterior choroidal artery and never had any neurological deficit. So we just wanted to mitigate this comment. And the other point I wanted to underline is the fact that the tools that we have in interventional neuroradiology are evolving every 6 months. And for instance, now we have the intrasaccular devices like the web device. And it's very useful for a large naked aneurysm, especially MC aneurysm. And these cases are nowadays very easy to treat by endovascular means, and we don't need any more stents or wide stenting, which are, I agree, could be very, very dangerous. So I just wanted to share this this new insight with all the neurosurgical community.
Okay, thank you, Clarence, and for this comment. I would like to ask a question for Professor Sainz-Martin regarding your experience about surgery in previously embolized aneurysms. What are difficulties and particularities for this kind of surgery, please?
Not many cases we treated, but usually it was easy cases. Recanalization was so high that the neck was free, and we was able to clip the neck, and the coil was peripherally. So we have such cases, and the result was good. But usually, if there is recanalization, so we do recoil. But in our center, we have very good cooperation. So we very rarely coil aneurysm with a wide neck. So I think we have very appropriate selection for coiling and endovascular treatment. So our retreatment is lower than these 19% because we really indicate only nice cases for endovascular treatment.
Okay.
Professor Benzeigmont, may I have a comment, please?
Yeah, please. Sure.
It's about surgery after coiling. We had a little bit experience about 3 cases, and one of the cases I presented. Remember you remember some in Colorado? It was a young girl. She was of course the first time we presented a ruptured aneurysm of the bifurcation of carotid. She had coiling, but not partially occlude, and then she had 2 years after the fluid diverter, and unless the fluid diverter, the aneurysm didn't be occlude totally. So I presented this case during the winter neurosurgical vascular neurosurgical meeting in Colorado, and all the friend and the participant advised me to operate in her. So we operated her, I think, a few months ago now, and she's very well. But it's really very easy to operate after coiling. What? Because we are in the situation like unruptured aneurysm. There is, of course, a little bit, of course, adherences with the dura, but it's less risk of bleeding. Thank you.
Thank you. Professor Mbey, maybe you have some comments regarding aneurysm surgery, please.
Thank you, Professor Mohammed. I would like, first of all, to thank the Moroccan Society of Neurosurgery for his invitation. It's a great pleasure to participate to this webinar. I would like to congratulate all the guy who had presented so amazing lectures. Professor Martin, there were very, very nice surgeries I saw, and also Professor Tleveler, this outstanding presentation. I have any I have any experience with coiling, or here in Senegal, I do not have the problem discussing coiling against clipping because we do not have the availability of endovascular option. So we have to operate all our patients. Maybe in a few years we will have this debate, but now it's not an issue here. I just would like to congratulate Professor Azari. I think we have the same difficulties, and I know I think the aneurysm surgery is maybe right now different if you between Europe or America and Africa, because we operate a lot of ruptured case, and I think it's more difficult than unruptured case, because like Professor Arzi said, we do not recognize very easily all the structures. The arachnoid is very thick, very with a lot of adherence, and I think it's more difficult. In example, here is our maybe more than 300 cases of aneurysm operated, maybe less than 5% was unruptured. So we have all the time to face those cases of subarachnoid hemorrhage aneurysm. I think it's more difficult. We have to I agree with him. You have to expect maybe the best, but you have to be ready for the worst, because sometimes it's very difficult. So I will finish. I have no question. I think everything was clear. Just a question maybe for Professor Martin. I saw you had clipped and fusiform aneurysm arising from ophthalmic ICA.
Yes.
And I don't know, is all the wall was sick or just one part of the wall? But in fusiform aneurysm, and in the image, in the pictures, in the videos, it looks like all the walls, the wall of the ICA was maybe sick. And I just wonder if the part you let down without no clip would not may cause issue after. But I just wonder this question: was all the wall thick or just a part of the wall? Thank you.
Yes, the fenestrated clip was appropriate, I think, and the wall was thick, and we follow the patients now 3 years, and there is no recanalization. I think that 3 clips, stacked clip, it was good improvement of the wall and good stability. So the follow up, it's nice. So no recurrence. So the wall was thick, I think.
Thank you.
Thank you, Professor Fube. I wonder if there is other questions from the assistants.
Maybe Professor Wahabi is here, and
yes.
There is echo in the sound.
I don't know if I don't know if you hear me.
yes. Yes, we
I
hear
have
you.
some problem with my connection.
It's okay.
Now it is okay.
Absamad, it's okay. We hear you very well. Oh. Okay, so maybe maybe I have a question waiting, Absamad, to be connected. Hi. And for our friend from Paris, our endovascular, the endovascular radiologist, it's in how many percentage in your team in PT Salpêtrière percentage you operate aneurysm and or embolize it?
But about 80%, 85% of the aneurysm are treated by endovascular means, and between 20 and 15% are clipped. So, and we are discussing all the cases in a multidisciplinary meeting, but most of the cases are nowadays embolized.
Yeah, things changed a lot from 1991. At that time, it's the difference. It's 90% surgery and 10% only with the.
I'm watching that every day.
Yeah. Okay, Absamad, are you ready now? Maybe he can not.
Maybe another question for Professor Martin is regarding giant aneurysms. do you go preoperatively for deliberate multiple fenestrated clips instead of bypass of doing bypasses, or it depends on the special location of giant of the aneurysm?
Yes, we like to do bypasses, but not very often. It's necessary to replace the flow through the carotid. So we always try to clip, because the high flow bypass or replacing the carotid, it's I think bring more risk. And fortunately, we all this big aneurysm was able to clip, but we do the prophylactic bypass because you need temporary clipping of the carotid, usually on the neck. And if there is insufficient collateral, so the prophylactic bypass is very good option for the surgery, because you are relaxed, because you have collateral flow and you have time for temporary clipping, suction. It's Dallas method. You can coagulate the aneurysm, you can shave the neck, and always we were lucky and we were able to clip the aneurysm with this prophylactic bypass and assistance with the temporary occlusion. So we never had to replace the carotid with the high-flow bypass in these cases.
Okay.
Can I add some things, Professor Retrosigmoid?
Yeah, please, Professor.
In our experience for the giant, just we asked the anesthetist to make the arterial pressure low, and to go with the clips on the sac, and after remodeling one by one, to go to the neck. And sometimes, for example, for MCA aneurysm, there is some perforators arteries, and coming to the perforators, we detach it, we dissect it, and we put the clip again and again to just to make visualization of the neck. And but the pressure should be very, very low. We ask to the anesthetist, and sometimes we make preparation for the temporary clip. For example, for MCA aneurysm, it's easy to put temporary, but just one trick, you have to put it after the lenticular striate, or after the perforator, which sometimes are arising from the M1.
Mm-hmm. Sure.
Thank you. Thank you.
Yeah. Can I?
Yes, Professor Mustashid, please.
So good evening, everyone. I want to thank all speakers for their high-level lectures relating to their great experience in the vascular surgery. I want to make a comment or to propose what's about the training program for young resident neurosurgery to develop macrosurgery in general and vascular. Second comment, do you, after a great experience, do you agree the following paradigm? First, expect the worst, be prepared, and make some prayer. Is it true after a great experience in vascular? Thank you.
Thank you, Professor Mustashid.
We have with us Professor Philippe Cornu. Maybe if you want to make a comment, can you please ask him?
Yes, Professor Cornu, please. Welcome, and feel free to make
Can you hear me?
to share with us your experience in this field. Professor Cornu, please.
Thank you very much for this very nice webinar. I thank the Moroccan Society of Neurosurgery for this excellent webinar. Of course, outstanding presentations from the different speakers. And I would like to say that I was relatively pleased to see that there is more or less consensus in the different indication in between endovascular approaches and surgical approaches, which was, I think, some years ago, much more difficult to in our discussions, for instance. But now there is, I think, and we have seen this tonight, that the consensus in between surgical indication and endovascular indications. The strategies are now more and more clear, and also to emphasize the importance to use in giant aneurysm the need of bypass in the strategy. Thank you again, and to my friend Hamsamad, congratulations also.
Thank you. Thank you, Philippe. Sure, we have a really relaxed atmosphere with the discussion about aneurysm surgery between our surgeons and endovascular this night. It's very special. Thank you for our speakers for nice atmosphere.
To thank Frédéric Carançon for being also and having accepted to participate to this webinar.
Thank you, Professor Corny. Now, maybe if the connection is, yeah, Professor Wahabi, please.
Wait, sorry. Okay, so sorry. I'm sorry if I had the problem of connection, so I can't have my question. But first, do you hear me?
Yes, yes.
Yes, very well, please.
I'd like to congratulate the organizer for this webinar and to congratulate and to thank the different speaker, Professor Tleveler and two other colleagues who gave a very comprehensive presentation on the management of aneurysm. And it's as it was said that this is a comment. It is true that after the ISAT, there has been a high enthusiasm regarding the endovascular treatment, thinking that will resolve all the cases. But with the experience of the colleagues doing endovascular and also with the time, we found that this enthusiasm has been tempered the way that we have the same experience like you, Professor Samis Martin, in Rabat. We have 60–70% still are clipping versus 35 or 40% coiling, and we have a very good endovascular team. But when we stick to the good indication of endovascular, not just putting stent, difficult material, following for months and months, angiography every 6 months, and then recanalization, etc., etc. When we discussed with the team, we found that at least 50% will go to surgery. At least 50% will go to surgery. As you said, the patients are young. The case with the neck, very large neck, dysplasic, MSAA, the aneurysm, giant aneurysm with compression syndrome, all this kind of aneurysm are better treated by microsurgery. Is it true that the problem now is like microsurgery and the microsurgeon who are capable to do this kind of surgery is less and less? And the other side, you have colleagues from endovascular getting a very good experience. This is the big problem in surgery of the aneurysm. We are losing expertise, and the other colleagues are taking experience. It's good for the patient for safety. It's not a problem of concurrence, but still, I think for the next 2 decades, they will be still placed for aneurysm to be treated by microsurgery. So you have to educate our young colleague to continue to do this. The flow diverter will never resolve all the cases. The coiling will never resolve the problem of all the cases. So we still will have for many years cases for microsurgery and cases for endovascular. This is my comment. And thank you for this very, very nice presentation. Thank you also, Professor Azhari, for this very dedicated presentation about the problem of techniques and the problem of anatomy. Thank you very much.
Thank you.
Thank you. Maybe one more question is in which way may the individual anatomy, vascular anatomy, could influence the choice of treatment, embolization versus surgery? The question is for both on the vascular radiologist and both speakers.
Frederick?
For us, the main issue is the large neck. Otherwise, we almost always can put the microcatheter in the aneurysm, almost always. The main issue is the large neck, and sometimes it's too large, and even with balloons, stents, or it's too difficult. So for us, it's the main anatomical issue.
Yeah, but to know all variation of anatomic system, I think it's a basic for the aneurysm surgery. So I think already in Yasargil books, I think it's everything, every variation, and I think it's a basic for this kind of surgery. And thank you for Frederick for a very nice comment about the new devices like WEB and the flow diverters. It's true, but France it's extreme country where there is a very high level of the endovascular, and the surgeons are very in minority. But still, we have no evidence about the new devices, and the web is good, but now we have no evidence for your enthusiasm. But we should wait for results, because all the endovascular are very happy, but they don't control the patients. I think they control the neurosurgeons. But we should wait for the evidence. But yes, this is true.
I think, Professor Bazagmout, that it depends of the configuration of the aneurysm. It don't depends of the anatomy. Anatomy you don't know. You don't know exactly where is the perforators, and sometimes you can have. For example, I showed before that some recurrent from the carotid, normally we have two trunks. We have the posterior communicating artery and the anterior choroidian artery. But sometimes we find three or four trunks. And sometimes three trunks from one artery. And the vascularization is the capsula. And if you take the artery, the small artery in the clip, there is hemiplegia. But you couldn't expect that. It's very difficult to explain because it's under the carotid. And I think to choose what our colleague from endovascular said is very important. It's to make consultation between neurosurgeon and embolization. And normally in emergency there is some hemorrhage, and we have to discuss the case. If it's even if it's a large neck, I can ask to the colleague from neuroradio if he can make some things for this patient. If he tell yes, we have to go in this way. And this consultation is very important, and it depends on the configuration of the aneurysm, not of the anatomy. Anatomy, nobody knows exactly the arteries, the perforators, and the structure around, and even the aspect. As you see, I show you some aspect of the arteries. It's disease. It's a disease of arteries, and sometimes it's really very fragile. And the endovascular can't know that, because he can't see the artery. He go endovascular, and you haven't idea about anatomy, but you have idea about the neck, the size, and perhaps if there is some multi-lobe for the fragility of the aneurysm.
Okay, thank you.
May I have a question, please?
Yes, please.
I would be to be more provocative and ask all the panelists and the speakers about the vasospasm. and the high-grade neurological grade of rupture aneurysm. It is not better to use the endovascular approaches in the same time to treat the aneurysm, to secure the aneurysm and treat the vasospasm with thrombolysis or dilatation. I worked with the endovascular, and one of the, in Morocco we have, I think, till now 3 or 4 endovascular radiologists, and one of them worked in our hospital. So I have a different experience now from when I was in public hospital. Now we operate between 30 to 40%, and all the patient 60 to 70% was approached by endovascular, and especially our colleague, endovascular colleague, received all the many neurosurgeons referred the patient directly to the endovascular. But we continue to discuss about multidisciplinary team and take this decision. And sometimes when some neurosurgeons from other centers refer their patients for clipping, and also the patient have to sometimes decide about the approach, microsurgery versus endovascular, and they refuse the microsurgery. Especially, I don't know whatever in other countries in Europe, but in Morocco we still have many patients refuse the microsurgery because opening the head is still something phenomenal. So what do you think about this? My comment, please.
About the vasospasm, you asked first.
Vasospasm and the high-grade patient with the high-grade neurological status, for grade 4, grade 5. Maybe we will, in our institution, we prefer to do endovascular because it's the status, neurological status is very worse, and we prefer the endovascular than microsurgery. I think it's the same in all centers in Morocco. What do you think?
The high grade hand has grading, so it depends on the aneurysm, and we do both endovascular and clipping. And about vasospasm, we control every day TCD, the velocity of the arteries. If there is more than 120, we use a 3H and augmented hypertension. If not sufficient, so we do angioplasty, but we don't do the mechanical. We use a corotrop, and we cooperate with our endovascular team, and they do intra-arterial local corotrop, and then we continue intravenously for 1 week. So it's good results, good cooperation with endovascular team, but indication it's on the TCD, it's 200 and more, and starting neurological deficit. Then we do angioplasty.
Okay, thank you.
So, may I have a question, Professor Benzemut?
Yes, Dr. Fed.
So I just want to ask another question about vasospasm. I don't know what is the strategy of Professor Samis Martin during his surgery to improve the outcome of patients regarding vasospasm. And is there, this first question, and the second question, is there any collaboration with the endovascular to improve the outcome included in your strategy? Thank you.
The second question was coagulation.
Is there any collaboration with endovascular radiologists in order to improve the outcome of vasospasm?
Yeah, vasospasm.
What is your strategy?
For the local after a clipping. So we try to remove all the clots and all the blood and wash it in the saline. And there were some plans for some trip of the nimodipine, but it's not working. So we do also papaverine, local papaverine, and remove the blood, and then we open lamina terminalis to improve the circulation of the CSF. And then we start with the prophylactic nimodipine in the ICU and everyday monitoring TCD. But within the operation, clot removing and the papaverine.
Okay, thank you. Frederick, do you agree with what we have said regarding vasospasm?
Yeah. For us in our institution, for high-grade patients, the physician from the intensive care unit ask us, the embolizer, to treat this patient because they are convinced that for high-grade patients, embolization is less harmful than surgery. So they are neutral, so they are pro-embolization for high-grade patients. And for the vasospasm, we used to do a lot of intra-arterial chemodilatation with nimodipine and chorotrop, but we have to do it every day, so it's very difficult. And so nowadays, what we do, we are doing angioplasty. It's a one shot, and usually it's enough to release the vasospasm. So we are doing more and more angioplasty. There is a small risk of arterial rupture, but it's very, very low if you are experienced.
With a balloon?
Yes, with a balloon, yes.
Local, only local,
yeah.
Local. Mm-hmm.
And it's just one shot. It's better than going every day to do chemodilatation every day for 1 week or 2 weeks. And
the mechanical dilatation, it's a long-term effect.
It's supposed to be. Sometimes it's recoil, but usually it's one balloon angioplasty is enough. Usually.
Excuse me. About balloon angioplasty, in many papers, the outcome is good for radiologic vasospasm, but for delayed cerebral ischemia, there is no difference if you do it or you don't do it.
In fact, you have two kinds of vasospasm. You have distal vasospasm, so you can only relieve this distal vasospasm with chemodilatation, and you have proximal vasospasm on M1, ICA terminus, A1. And for the proximal vasospasm, usually the balloon angioplasty is efficient. But sometimes you have to do both chemodilatation and proximal angioplasty.
Thank you. Thank you.
Thank you. We are now more than 2 hours in this wonderful webinar. And maybe if there is no more questions, the ending words will be for Professor Labadi, the director for the Morocco neurosurgical webinars. Professor Labadi, please.
Thank you, Professor Retrosigmoid, for this nice moderation. And also, I would like to thank all the speakers for their outstanding talks, and also to the panelists to moderate, Professor Retrosigmoid, Professor Frederick, and Professor Tube also, and the participant, and our comment from our senior neurosurgeons. Thank you so much to be with us lately. Thank you to all the participants. And I give you the next Tuesday at 6 o'clock, every Tuesday at 6 o'clock, the next webinar, it will be treated, I think, a field of spine. So thank you so much to all of you, and hope that you enjoy this evening with us. Thank you.
Thank you. Bye-bye.
Bye-bye. Thank you.
Thank you. Bye-bye, Marty.
Bye. Bye-bye.
Au revoir tout le monde. Bonsoir et bon week-end.
Thank you, everyone.
Where are you?
Bye.
Bye-bye.
Bye.
Bye-bye.
Assalamu alaikum.
Bye-bye.
Au revoir.
Ciao, ciao.
الو السلام عليكم السي ايوب.